We can barely hear you in Rochester.
Okay, let me know.
I can barely see you, too.
It's a long table.
We can see what we're seeing.
Is that John?
Can you hear me now? Sounds like
Yeah.
Okay.
We can see it, too.
No, Ralph. Is that Ralph Fasano
Yeah,
with
I think
Tino?
so.
It looks like it.
Okay.
I'm Tino Hernandez, Vice Chair of the Projects Review Committee. Dr. Martin will not be joining us today, so I'm going to go through the parts that we're considering here today. I'm here with Ralph Fasano. Who's up in Albany?
Sue Wheeler,
Bill Getman.
Keith McCarthy?
Kathy Bovelang,
Janet Pulaski.
Gail Keeler,
Diane Gurdon.
That's a lot. How about, that's Rochester?
Rochester, John Lee.
Allison Batone from Hillside.
Ken Luder from Hillside.
Maura Kelly from Buffalo.
Okay, we have OMH and Oasis staff.
Yes. Right
Okay.
here.
yes.
Okay. I think I'm gonna move out of order for a moment and put aside the OMH one, which I think we had conditionally approved before. Is OMH, who's there from OMH?
Keith McCarthy, Director of Inspection and Certification.
Okay, my recollection is that this was conditionally approved at the last meeting,
You're
and that they were,
talking about the Center for Discovery project?
yes,
Okay.
and that the full council had concerns about the staffing plan. And I have-
No, actually, I think you're thinking about a different project. This project was from last summer. It was approved. And the project, they were unable to find a location in Westchester, so they are now requesting to relocate to Suffolk County on Long Island. So that was why we're representing.
This was presented twice already. This is the third. So the first time, you're correct, we had questions on staffing, and they were adjusted. They adjusted their staffing plan, and the second time it was given conditional approval, and now the project, the applicant was unable to find a location, and has changed to Long Island.
From Westchester to Long Island?
Yes.
All right, so that's the issue with the staffing plan has been amended and fixed.
Yes.
Okay. So, then really the only issue outstanding is that they're relocating to Suffolk County from Westchester.
Yes.
Okay. Does anyone have any questions on this particular project?
Does this move impact their fiscal viability or their service delivery at all, that you can tell?
Everything is sufficient.
Yeah, the program remains intact. Just that
Speak up. Rudy Arias, our project director for this, project manager for this one.
Yeah, the entire project is the same one, the same type as we previously reviewed and approved. The main difference is that they will be operating out of Suffolk County, and the targeted population will remain the same, and they will continue to take referrals from all over the state, just as previously planned.
Thank you.
Okay, we have a representative here from the program. Your name?
Tim Davis with Center for Discovery.
So there was an amended staffing plan.
Yes, there was.
We had some concerns, I think, about the medical staffing.
Yeah, we added more psychiatric coverage and nursing coverage as well to kind of cover the medical aspect, which I think was people were concerned about at this too.
Okay.
So.
All right. Any questions from any of the council members?
No.
No.
Okay. Can we call a vote on this? All in favor? Say aye.
Aye.
Opposed? Abstentions? Okay, so we'll recommend to the full council that this be approved. Thank you. Now we go to Oasis. The next one is Epic.
You know, Epic, OMH, and Oasis both have Epic, so maybe we want to kind of do them together. We'll do our Epic, and then maybe they can do theirs.
Okay.
Okay?
So Epic, as I understand, is a change of sponsor, change of ownership, right?
Right. It's
The applicant is Epic Family of Human Service Agency submitted. They submitted an application really to become the parent entity of South Shore Child Guidance Association.
correct.
You want to walk us through this?
Sure, Diane's going to do that for you.
Good morning.
Okay.
Okay, so again, just what you said, EPIC is a New York not-for-profit corporation, and it's licensed by both OPWDD and the Office of Mental Health Article 19 program. And South Shore is an Oasis licensed Article 2032 outpatient clinic. Due to a variety of reasons, including financial, the two organizations determined it's in their best interest to look into different possibilities to operate in a more efficient manner, which would better serve the clientele in the community, which they are both serving. Epic and South Shore determined that a formation of a common parent entity to assist with administration and general oversight of both agencies will be, EFSA will be the sponsor of South Shore. The board of directors will be comprised of at least a majority of individuals who are also directors of EPIC and South Shore. The parent entity will be the sole member of the EPIC Long Island, and EPIC Long Island South Shore will have two classes of members, the parent agency and independent members, who will appoint 25% of the South Shore board of directors. The independent members cannot have any relationship with or be appointed, removed by the parent entity. The parent entity will have all the rights of members under the New York Not-for-Profit Corporation law, including election and removal of directors, except as limited by independent members' authority with respect to South Shore. Approval of amendments to the certificates of incorporation and bylaws. Approval of the sales of all substantially of all the assets of EPIC and South Shore, and approval of any merger, consolidation, or dissolution. South Shore will continue to provide outpatient substance abuse at its Oasis licensed Article 32 outpatient clinic. The need was not reviewed as there's no changes in services or the population currently served by both providers. The local government unit comments were received by the Bureau of Certification and Systems Management on May 19, 2015, signed by James Dolan, Director of Community Services for Nassau County Office of Mental Health, recommending approval of this proposed action. The Long Island Field Office comments were received by the Bureau of Certifications and Systems Management on June 5, 2015, signed by Evelyn Zamir, Program Manager, Antoinette Witt-Eter, Regional Coordinator, and co-signed by Stephen Rabinowitz, Downstate District Director, recommending approval of this proposed site and an approved base level funding of $269,747 state aid is committed to transfer of EPIC Family Services to continue to administrative services. Both providers made their public intent to merge, and they established a management agreement in 2014. Community outreach was not required, again, as this current application as existing services. However, in November and December of 2014, Sherry Lurie, the Director of Mental Health, with Anthony Zenkus, Director of the Safe Center of Nassau County. At that time, they expressed support for the proposed partnership, which he described as being consistent with the goal of active collaboration between local agencies. Informal discussions with other community agencies have been very positive with regards to the proposed mergers, and no concerns are being expressed. EPIC Long Island Outpatient Mental Health Clinic admits and provides mental health services to individuals who also have co-occurring substance use disorders but those individuals must meet EPIC's admission criteria and be able to participate in outpatient mental health program. EPIC mental health clinical staff are expected to collaborate with the OASIS licensed programs to facilitate the provision of integrated treatment model in which traditional chemical dependence and mental health programs seek to manage multiple symptoms of their presenting patients by incorporating techniques of mental health and or addiction screening, assessment, and counseling into their own spectrum of services. South Shore has been an OASIS licensed provider since 1995 as a Part 822-4 Chemical Dependence Outpatient Treatment Service. Their most recent performance review was conducted in March 2013, which resulted in substantial compliance for operating certificate number 10993, effective date April 1st, 2013, with an expiration date of March 31st, 2016. The applicant submitted a separate signed and notarized Appendix 4 character and competence for each affiliate, as well as for the required governing authority questionnaires. EPHSA identified 11 board members, board of directors, and South Shore identified 6 board members. No areas of concerns were noted in review of those documents. Tom Hopkins, President, CEO, is a human service professional with more than 30 years of experience working with people with disabilities and their families. In March 2009, Thomas Hopkins and clinical director Sherry Laurie developed and obtained a license for EPIC Clinical Care, a mental health clinic, to provide services to individuals who are dealing with emotional and psychological problems. Jeffrey Nagel, president of the EPIC Board of Directors, have been actively involved with EPIC and the Epilepsy Foundation of Long Island for more than a decade, and he has served on their board since 2007. Financial feasibility, Long Island Field Office Program Manager Evelyn Zamora reviewed and approved the budget for this proposed service. And Bureau of Certification Assistance Management on June 15, 2015, received from Rudy Arias, Project Manager of New York State Office of Mental Health, a statement regarding the applicant's fiscal viability, which he stated that after reviewing the 3 most current years of audited financials for EPIC, our budget analysis considers them in acceptable fiscal health. A physical plant inspection was not required for this action, as the Part 822-4 outpatient program will continue to operate at their existing site, which has been an approved certificate of occupancy and met regulatory compliance standards as determined by New York State Facility Evaluation and Inspection Unit. OASIS's recommendation is to approve the application from EPIC family of health service agencies to become a certified sponsor of the program currently operated by South Shore Guidance Incorporated, with the following contingency: filing receipt from the Department of State.
Okay. Anything else to add? Seems pretty self-explanatory. Do council members have any questions? Comments? No. Okay. So can we call a vote? All in favor, say aye. Aye. Opposed? Abstentions? Thank you. Okay. We'll recommend to the full council that it be approved. All right.
Okay.
I'm going to continue on. Exodus Transitional Community.
First, can we just, Tina, could we possibly take a vote on the OMH application as well? I'll just introduce it quickly and then have a vote. It's the same application, just on the OMH side as well.
Okay.
As Oasis just explained, the intent of EPIC Family Human Services agencies. We likewise at OMH need to have them established as a mental hygiene law Article 31 sponsor for OMH purposes. Each of the agencies, as stated, will continue to exist as their respective provider agencies. Both programs have operated in compliance with OMH regs since their start: South Shore Child Guidance Center since '93 and EPIC Clinical Care since 2010. And OMH recommends for approval.
Good. Any questions, comments? All in favor, say aye.
Aye.
Opposed? Abstentions? Okay, we'll recommend to the full council for approval. Thank you.
Thank you.
We'll move on now to Oasis. I guess the first one is Exodus Transitional Community.
Okay. Good morning. I'm Gail Keeler. We do have representatives here from Exodus. Exodus Transitional Community has submitted a certification application requesting to become a new Oasis provider of Part 822-4 outpatient services located at 2271 3rd Avenue in New York. Exodus has been established at this location for more than 13 years, providing a range of services to individuals re-entering the community after time spent in prison. CD services will be provided on the second and third floors of the building with separate entrance. The applicant states that many of their current clients suffer from drug and alcohol problems, and they feel that by establishing a program within the facility, the clients will have a much better chance of actually accessing the services, and it will enable them to provide a wider range of services to their clients. They anticipate beginning with approximately 25, increasing gradually to about 100 to 125 by the end of the first year. Exodus Transitional Community was established as a domestic not-for-profit in New York City in July of 1999. They operate on the belief that individuals released from prison need resources to support their transition back into mainstream society. They use a holistic approach to providing services focusing on 6 major target life areas: employment, education, family, spirituality, health and physical fitness, and community involvement. The board of directors is made up of 13 individuals representing a range of professions. One of the board members, Mr. Joseph Turner, is the co-founder and a longtime board member of Exponents Inc., which is an Oasis certified provider. Mr. Turner states he has also recently completed the application process to become a board member of Friends of Recovery New York. Need methodology figures from March 2013, which are our most recent figures, show that New York County is currently meeting 98.4% of the need for adult outpatient. New York City Department of Health and Mental Hygiene submitted a recommendation to approve on June 8, 2015. Oasis Upper Manhattan Field Office also recommended approval. The application included a letter of support from New York City Community Board 11, as well as a letter from the Deputy Commissioner of Adult Operations, the New York City Department of Probation, also expressing support for Exodus providing the service. Policies and procedures have been reviewed and are in compliance with regulations. Staffing plan submitted meets the requirements for a Part 822 outpatient service. Includes a one full-time clinical director, a program coordinator, 0.2 FTE medical director, a consulting physician's assistant, nurse practitioner, beginning with 1 hour per week, increasing as needed as the census grows, a full-time case manager KSAC, a full-time case manager KSAC-T, an intake assistant, 2 facilitators, and support staff. Fiscal viability review was completed in July of 2015 and found the applicant's current and overall financial positions to be viable. The applicant submitted a balanced startup budget for the first 6 months, as well as one for a full year of operation. All revenue will come from Medicaid fee-for-service. The budget takes into account an expected 20% no-show rate. It demonstrates a reasonable number of services provided per client over the course of the year. They will cover operating expenses for the first 6 months by local government grants, cash donations from closely allied entities, and Exodus general operating funds. No Oasis funding is requested. A floor plan review found the proposed space appears to be adequate for the proposed service, and a certification inspection was conducted in September 2014 and found the facility to be in compliance. Oasis recommendation is to approve the request from Exodus Transitional Community to become a new Oasis provider of Part 822-4 outpatient services with the contingency of receipt of the filing receipt from the Department of State for the addition of our language regarding the change in corporate purpose and verification of that they have hired staff to meet regulatory requirements.
Okay, specialists in the room?
Yes, they are.
Yeah. So, as I understand this, this is a prisoner reentry program. People coming out of prison are referred to Exodus, and Exodus works with them to integrate them into the community. Oh, you're here. Oh, yeah. I thought you were there.
There's some here in Albany.
Some in Albany, some in New York.
Yeah, they're here too. So that's your primary mission.
Yes.
When you indicate that a lot of your clients live within a 5 or 10 block radius, do you run housing, or is it that they tend to move and stay in that area?
They're released in that area. 2,200 people are released in the East Harlem area, 119th, 126th Street. So it's a concentrated population. Again, that's coming directly from state prisons back into the community.
Okay. Did Rosanna Rodado work with you? Okay. Yeah, I remember her speaking to me about your program. All right, any questions from the council, the committee members?
Yes. Are these people on parole and are they mandated to go to the services?
Most of the people on program on parole, they will probably be mandated as parole now starts finding out that we are a licensed agency. We do have some groups now where people are mandated. So I would say about 60% of our participants who walk in our doors are mandated. The other 40% are walk-ins that maybe got been out for a year, heard about our program, and decided to come in.
Okay, thank you.
Do you do like outreach or inreach within the prison?
Yeah. So we're in Fishkill, we're in Green Haven, we're in Sing Sing.
Okay.
And we're in Owensville.
Okay. All right. Will people from the community have access to the outpatient program if they're not necessarily involved in your program?
We usually have a 10% walk. As of right now, we have a 10% walk-in. So it's my family member, maybe looking for a job or wants to use our computers, needs access to resumes. So right now it's about 10%, but we would open that up to the community as well.
Okay.
Do you plan on doing outreach to the parole officers to inform them of your program?
Yes, we have an excellent relationship with parole. They've already been informed and they're excited as well about the opportunity to work with us.
Any other questions?
Question for fiscal startup for 6 months, they're basically absorbing the cost.
Yeah. Well, they have, they said cash donations from closely allied entities, but they're general operating funds. They've been in existence for a while.
Okay, thank you.
Also a grant.
Question for Oasis. So we're taking applications for fee-for-service Medicaid, but is a program like this anticipated to be folded into the managed care process?
Yeah. Yes.
And is the provider prepared for that? Are you aware of the changes within this type of program, and that you'll be receiving your payments from managed care companies, and there's a lot of data and things that will be necessary? Is that something
We've heard about the process.
We also have Tracy in our office who does managed care as well, and we are in the process of greatly updating our tracking and outcome management programs and technology, so it's viable. There'll be a dedicated person for that piece, for the billing piece, but also for the data management as well. So we have quite a few government contracts that are required to with that data as well as to manage that.
Okay.
Any other questions?
Yes. Are you going to provide care coordination and address the whole needs of the person? Or are you in collaboration with other people, with other organizations to make sure all the needs are being met?
Yes, we have linkage agreements with other agencies that can help with medical care and mental health.
Thank you.
Okay, you have relationships with healthcare entities. This is in Holland, right?
Housing as well is always
In
an
housing,
issue,
okay.
right? That's always something that's not for.
Okay. I mean, I would forewarn my colleagues, point that, we are sort of, moving, they're carving substance use in and going to a Medicaid managed care model, which is going to happen right around the time that I think you're going to be starting, so you have to be prepared for that. Any other questions? Can we call the vote? All in favor, say aye.
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 Opposed? Abstentions? Thank you. We will propose it to council for. Okay. Next is South Brooklyn Medical Administrative Services.
Okay, this is a simple change of ownership.
Right.
The proposal is for a change of ownership, which currently affects Operating Certificate 10387, a Part 8225 opioid treatment program, located at 685 3rd Avenue, Brooklyn. South Brooklyn Medical has treated individuals for substance use in the community for over 35 years. Their status reflects substantial compliance. Historically, there have been two owners, Dr. Arthur Zaks and his wife, Mary Zaks. Dr. Zaks passed away, and now Mary Zaks will be the sole owner. Ms. Zaks has a master's degree from New York University and has been the vice president of the corporation since 2004 and has been involved with the daily clinical operations for over 10 years. We also have documentation from the attorney. James Struhl confirms that Mary Zaks, per probate, confirms her as the sole beneficiary. There are no changes to the service description. The same policies and procedures will continue to be utilized, having been reviewed and met regulatory standards. Staffing remains the same and meets regulatory standards for a Part 8225 opioid treatment program, and the services will still be delivered to the same population. On February 10th, 2015, Jane Gifford of the Oasis Fiscal Review Unit issued a fiscal viability report which stated that the current and overall financial position is viable through 2018. The Brooklyn Field Office Manager Bill Cruz reviewed and approved the proposed budget for the service and recommended approval for this proposal on May 7th, 2015, and that was co-signed by Regional Director Sheila Roach and District Director Stephen Rupinowitz. The local governmental unit comments were received April 8th, 2015, recommending approval, signed off by Luke Bergman, Director of Recovery Services, New York City Department of Health and Mental Hygiene. In October 1st, 2014, the applicant sent correspondence to Mr. Laufer, District Manager, Community Board 7, apprising them of the proposal, and there were no concerns related.
Okay. Any questions from the committee members? The Arthur and Mary Zaks were co-owners, or
Yes, they were the.
I'm sorry?
Yes, they were co-owners, and now she's going to become the sole owner since his passing.
Okay. Any questions?
No.
If not, let's call the vote. Okay, all in favor, say aye.
Aye.
Opposed? Abstentions? Okay, we'll recommend approval to the full council. New Horizon Counseling Center.
Hi, that's me again, Gail Keeler. I believe there are representatives in New York City. Yes?
Okay, yes.
New Horizon Counseling Center has submitted a certification application requesting to become a new OASIS provider of Part 822-4 outpatient services located at 50 West Hawthorne Avenue in Valley Stream. New Horizon has been issued a temporary operating certificate for these services in March of this year when the previous operator, Peninsula Counseling Center, decided to discontinue operations. New Horizon Counseling Center was established as a domestic not-for-profit in New York in December 1981. They have operated behavioral health clinics and community-based social services programs in the New York City area for more than 30 years. They're currently also licensed by both the New York State Department Office of Mental Health and Office for People with Developmental Disabilities. The board of directors is made up of 8 individuals representing a range of professions. 2 of the board members identified prior chemical dependence experience. 1 has served as chairman of the New York State Health Facilities Association, and in that capacity has assisted organizations seeking OASIS approvals. Another has more than 15 years of administrative experience overseeing inpatient detoxification units at 2 New York City area hospitals as chairman of medicine. There are no community concerns anticipated, as this is an existing service with no changes other than the change in operator. Peninsula Counseling Center had established communication and collaboration with a number of community groups, and New Horizon has begun establishing those relationships themselves and will continue that collaboration. Nassau County Office of Mental Health, Chemical Dependency, and Developmental Disabilities submitted a recommendation to approve in May of 2015. New York City Department of Health and Mental Hygiene, which is the LGU for the applicant's administrative location, also submitted a recommendation to approve. OASIS Long Island Field Office recommended approval as well. Policies and procedures have been reviewed and are in compliance with regulations. There are no proposed changes to the existing staff, which includes a director of services, part-time medical director, a part-time nurse practitioner, 4.09 FTE counselors, LCSW, 2.02 FTE counselor CASACs, and support staff. Fiscal viability review was completed in July 2015 and found the applicant's current and overall financial position to be viable. New Horizon will adopt the budget previously associated with Peninsula Counseling Center. OASIS Field Office has confirmed and approved one-time funding for 2015 on a prorated basis and continuing base-level operational funding at a rate that will be determined during annual performance reviews. They also have local government grants. A facility review was not requested, as this is an existing and approved location. It was last inspected and approved in February of 2014. OASIS recommendation is to approve the request from the New Horizon Counseling Center, Inc., to become a new OASIS certified provider of Part 822-4 outpatient services at 50 West Hawthorne Avenue in Valley Stream, with the contingency of the receipt by OASIS of the filing receipt from the Department of State for the added language for the change in corporate purpose.
Okay, you're operating it now. You have temporary operating.
They are, yes.
Okay. I'm a little bit more curious about Peninsula Counseling Center. They're discontinuing their OASIS, OMH, and OPD, WDD programs?
Yes.
How come?
That I don't know.
Are those programs being transferred to another operator?
From OASIS standpoint, there's only the one, and that went to New Horizon.
Oh, okay.
Yeah, New Horizon.
Operating them already.
Should we talk?
Yes.
All of the Hi, this is Eric Lieutenant Flora Beanstock from New Horizon Counseling Center. We're the co-directors of the agency. All of the programs just questioned regarding Peninsula Counseling Center were taken over by New Horizon Counseling Center with all the state, local, governmental unit approval, including OMH, OPWDD, and of course today, upon the request of the OASIS program.
And we've been operating these, different services since already over 4 months, maybe 4.5 months already. So we've been operating these.
So we're glad you took them over. Do they appear to be sustainable? I'm imagining that Peninsula gave them up because of financial difficulties.
Correct. Peninsula was having financial difficulties. New Horizon reorganized it, but complied with the existing programmatic guidelines. And due to New Horizon's fiscal viability and strength, we're continuing the programs. And the current census is back up to the 180, while during the Peninsula time, the census went down below. So the community is very happy that services are being continued. We've outreached to the community to raise awareness that the program is intact and New Horizon is there to continue to provide services.
Same question as to the other provider. Are you prepared for the managed care?
Absolutely. New Horizon has all the contracts in place with managed care and also all the value-based systems in place, computerized and programmatic, to be successful in what's upcoming.
Any questions from the committee members?
This might be a redundant question, but you have funding for the first year. How are you going to have sustainability in the upcoming years following that first year?
OASIS operating funds will continue. They just haven't determined the exact amount yet. That'll be determined during performance reviews, but field office has committed to continuing base level operational funding.
Okay, thank you.
Any other questions? We can call the vote. All in favor say aye.
Aye.
Aye. Opposed? Abstentions? Okay, we'll recommend to the full council approval.
Thank you.
Thank you very much.
All those. Actually, don't have that here.
That won't make sure it says.
You have Charles Evans?
Yes, but did Oasis have one more project, or were you done?
We have a capital project. We have one more, Tino, if you want to finish with Oasis.
Okay. Oh, that's the VIP?
Yeah, VIP capital project.
Yeah, okay.
All right, go ahead, Di.
Okay, this proposal is for both a capital project at 770 East 176th Street in the Bronx. The building has to be demolished as it is in very poor condition. It was built in 1974. Once construction is completed, all VIP programs will then relocate to 176th Street site. The programs affected by this action are a Part 822.4 CD outpatient and a Part 822.5 opioid treatment program and some offices. Both have already been temporarily relocated to VIP's Arthur Avenue site. Consideration was given to permanently housing the Oasis programs at the Arthur Avenue site. However, that existing 9-story building requires extensive renovations as well. So that, coupled with an outstanding IDA bond debt in excess of $8 million, the total cost of the project to renovate Arthur Avenue was estimated at $31,494,000. The 770 East 170th Street property is currently owned by the state of New York and will be transferred to VIP upon completion of the renovations. In terms of the impact on their operating budget, there will be a need for debt service of $1,407,549 based on an interest rate of 2% and bonds sold for 20 years. This increase will be offset by the reduction of current property costs paid to VIP for the Arthur Avenue site, resulting in a yearly increase of $882,549 in their operating budget. The Oasis fiscal coordinator, Jane Gifford, did a fiscal and viability review on July 14th, 2015, and determined their current and overall financial position is viable through 2017. New York City Department of Health and Mental Hygiene recommended approval on June 16th, 2014, signed off by Luke Bergman. He states VIP operates one of the largest licensed medically supervised opioid treatment programs in the Bronx, serving more than 10,000 clients per year. Certification will allow for additional levels of service. VIP anticipated community concerns with the relocation of the OTP clinic and discussed their plans with Community Board 6, who gave their support, as well as Senator Gustavo Rivero, who submitted a letter of support. The New York State Oasis Bronx Field Office recommended approval on August 4th, 2014, signed off by Program Manager Alex Akacha, Regional Coordinator Gideon Rubino, and Downstate District Director Stephen Rabinowitz. So we recommend approval.
Any questions?
Is there going to be any impact fiscally when they move to the other site? while the construction's going on?
They've already moved.
Already moved,
They're
so
already
they're-
at Arthur Avenue
2
now.
years ago, that relocation was done.
Okay, so, all right, good.
Who owns both properties?
Okay, Oasis owns the one at the 176th Street. And
VIP owns the Arthur Avenue.
You're going to transfer ownership.
Of the new site, yes, to VIP once the construction's done, and the Arthur Avenue will be VIP's building to get rid of, or whatever they want to do with it.
Any other questions? Well, hearing none, we call the vote. All in favor, say aye.
Aye.
Opposed? Abstentions? Okay, again, we'll recommend approval from the full council. Thank you. And then I had missed Evans, huh? Evans is only?
Yep, Charles Evans Center.
Okay.
Start with that one?
Yep.
Okay. Charles Evans Center, Inc. Operates a Department of Health approved diagnostic and treatment center, which is also designated as a federally qualified health center in Bethpage of Nassau County. The applicant currently provides mental health services through the DNTC FQHC, but are approaching the thresholds necessitating OMH licensure. Charles Evans Center has recently become the operator of the DNTC, which was established and previously operated through the Association for Children with Learning and Developmental Disabilities since 1999. The Association for Children with Learning and Developmental Disabilities is well known to the OPWDD community, Department of Health, and Nassau County. The applicant will continue to provide primary care to the established area through the FQHC. The addition of licensed mental health services will enhance an integrated services model of care and utilize evidence-based practices. OMH notes that while there are 12 mental health clinics in Nassau County currently, this is the first proposal to offer specialized, culturally competent services to individuals with co-occurring developmental disability and mental illness, an underserved population. One of the conditions being applied is for the applicant to confirm that the population to be served will be those individuals with co-occurring developmental disability and mental health diagnosis who can both consent and participate in their treatment. They also are directed to work with the field office to develop acceptable plans for the provision of mental health services for children, adolescents, and families. And OMH recommends approval.
With a number of conditions.
Any questions?
There's a number of conditions here that Keith identified. The applicant's okay with these conditions?
Charles Center is there?
Yes, we are.
In fiscal viability, there's a lot of noise and talk about clinics are always having trouble. This is fiscally viable?
Because it's an FQHC, yes.
Okay, because of the rates they get? Okay, good.
Any other questions? Well, hearing none, we call the vote. All in favor, say aye.
Aye.
Aye. Opposed? Any abstentions? Hearing none, we'll recommend to the full council approval. Okay, thank you.
Thank you.
So I think we're done, right?
No, we've got 2 more OMH projects.
Do we have more?
We can go all day if you want.
You're more efficient than Dr. Martin, Tina.
We won't tell them.
They should have been.
What's that?
Hillside.
The next.
Children's Center folks are here in Rochester.
Okay, we can go with that one next. And then we have West Islip Youth Enrichment Services. So any preference?
Sorry?
We have West Islip Youth Enrichment Services. I believe they're there with you in the city. And we have Hillside Children's Center in Rochester.
Your choice.
Let's go upstate.
Okay, we'll go upstate. So next we have Hillside Children's Center. The applicant proposes to reduce the capacity at the Hillside Children's Center residential treatment facility from 42 beds to 34 beds. Decline in RTF utilization across the state has impacted the number of referrals for admissions to the RTF. In December of last year, the RTF was forced to reduce operational capacity from 42 to 34 to address the decrease in demand for beds, as well as quality of care concerns by OMH. The agency had been cited for a number of restraints at the RTF, but with OMH oversight and technical assistance, they've achieved many improvements since October of last year, having developed a very comprehensive plan for reducing restraints and achieving incremental objectives. The plans resulted in changes in leadership and day-to-day program management and supervision, and restraint data has shown a consistent reduction in restraints in meeting targets, such as 20% reduction for the first quarter of 2015. The proposal to reduce capacity is being done with OMH support to allow the applicant to better manage the RTF. With a reduction of 34 beds, the RTF has been operating at near capacity, and OMH recommends approval.
Okay, any questions?
I guess the application talked about a national trend towards reducing RTFs. Is that because we're favoring treating more people at their homes as opposed to residential treatment?
I think that's part of it.
The other part I would suggest is that the process of admissions to the RTF system is very difficult at best. It differs by region. The PAC process can be a little cumbersome in some regions. It's just hard to get kids in, and without utilization, then fiscal viability gets to be pretty tricky, but I don't want to speak for Hillside.
Well, when we look at our utilization, if I go back to at least October of last year, we averaged around 36 youth in program per day started in October, so we were looking at 6 admissions. I think there is a push to keep kids in their community with services that support them in communities as much as possible. But we really look at our trending data, our numbers have steadily been going down.
And I can say that the OMH, Office of Children and Families, has been exploring, and they've said this quite publicly, that they're looking for alternative uses for RTFs moving forward, and they're exploring a host of options.
Any other questions? Okay, hearing none, can we call a vote? All in favor? Say aye.
Aye.
Opposed? Abstentions? Hearing none, we will recommend to the full council approval. Okay?
Okay.
Next.
And last but not least, we have West Islip Youth Enrichment Services, which goes by YES. YES requests OMH approval to become an Article 31 sponsor for purposes of establishing a clinic to serve children and adolescents aged 5 to 21. The program expects to primarily serve residents of the town of Islip, but will be open to the general public. The clinic will provide only collateral services to adult and unadmitted family members. YES has a history of collaborations with several New York State agencies, including the Office of Children and Family Services, the Department of Labor, and the State Education Department, as well as the County of Suffolk, the YMCA, and the town of Islip, and neighboring public schools. YES currently operates 8 OCFS licensed after-school programs, indicating that they target at-risk youth and families. The applicant indicates that it recently assumed responsibility for unlicensed, non-billable counseling services provided to youth and families by the town of Islip, and the town's agreed to provide YES annual funding and free space in the municipal building for the operation of the clinic. And OMH recommends approval.
Any questions?
So the free space in the grant will offset any loss, right? On the clinic building?
The budget is, actually, they're going to have a surplus of about $250,000 with the money from the town. So, I mean, there's no problem at all.
But absent that money in the free space, they'd be in a...
They still would have a $50,000 surplus with absent the $200,000 in cash. If they should lose the space, it would be an issue as to how much space, equivalent space would cost, because then they would have their surplus of $50,000, but it's not clear as to how much space costs there. But they indicate that the town sent a letter of intent indicating that it expects to sign agreements over a course of 2 years for the space, so we don't think that'll be an issue.
And Bill, we have the applicant is in the city as well as, I believe, a representative from the town.
Yeah.
The applicant is here? Yes. we have the applicant here in the city. Do we have any questions?
So it's very impressive that you had such support from the town. I want to tell us a little bit about how you got that.
Well, we've been a subcontract agency out of the town for over 25 years now. We have a great relationship with the supervisor. The town vice supervisor is actually a founding member of YES. And we just, built up a reputation over all these years. We're like the only agency really doing all of these services.
Basically, the town created, so they are doing our work for us. So we want to support them in any way that we can.
Why is the space available only through December of 2016?
We have a new leasing agreement that's approved every year. We'll continue to get the spaces as long as we need it.
It's on the EU.
Yeah, they only do yearly.
Yes. Okay. Any other questions?
No.
Okay. Well, hearing none, can we call the vote? All in favor, say aye.
Aye.
Opposed? Abstentions? Okay, hearing none, we'll recommend approval to the full council.
And now we're done.
Yes, I'm off the hook now?
You're off the hook.
Did a great job.
We'll report favorably back to Dr. Martin.
I need a cup of coffee. Thank you.
Thank you.
See you later.
Happy July, happy summer, everyone. Nice sunny day. Why don't we just quickly go around the room so we have on the record in time. Let's start with Rochester, please.
Scott Lee, Seneca County, Department of Smell Hygiene Directors. John Lee, CCSI.
Maura Kelly, Mental Health Care Protection.
Okay, and in Albany, please.
Susan Wheeler, Star Group.
Bill Gutman, St. Catherine's Center for Children.
James Fordo, Grado Community Center. Rob Chen, Oasis.
Dan Sullivan, OMH. Sherry Gillette, retired DCS and consultant.
Patrice Wallace-Moore.
And here in New York City right now. Paul Samuels, Freeze.
Tino Hernandez.
Ralph Paceno.
Howard Beaton. Lawrence Brown. John Castan. Who's it, Bernstein?
Susan Oren.
Welcome, everyone. The first items on the agenda are to approve the minutes of the April 22nd and June 25th meetings. So let's start with April 22nd.
So moved.
Is there a second? All in favor?
Aye.
Any opposed? Any opposed? Okay, it passes unanimously. And now the June 25th minutes.
Move.
Dr. Brown.
So moved.
Okay, second, right? All in favor?
Aye.
Any opposed? Any opposed? Okay. And also approved. And we go straight to the commissioner's report in Albany, please.
Okay, hi everyone. I hope everybody's having a good summer. I'm going to give a couple of updates on some things that have been happening, and then feel free to ask any questions. The first is on managed care, and I think as everyone knows, we are going to be going live on October 1st with moving all the seriously mentally ill and substance use into managed care, and it's going to happen. It will happen on October 1st, no more postponements. We've been doing a lot of work in terms of provider readiness, managed care readiness. We're hopeful that we will be able to do some mock billing before the bills actually have to go through, so that we have some confidence that the system will work well for those people who have not so far been billing managed care, Medicaid. We've been working very closely on how to monitor the dollars that are going to be being spent. The MRT recommendations, I believe, have been really well incorporated into the contract, which includes monitoring the behavioral health dollars that are in the HARP, as well as monitoring the behavioral health dollars that will be newly moving into the mainstream plan. So I think that we're in good shape to kind of keep an eye on what's happening. We're going to have to make sure that both us and also the regional planning councils that are going to be happening upstate and the one in New York City are in good shape. Upstate won't start for another 6 months, but they have to kind of get together. But the one in New York City has been formed, and they will also be keeping an eye on what happens with the rollout. We will still be educating consumers. I've just asked staff to also send out some education again for providers that this is happening, that consumers will be getting letters that will say that they will be passively enrolled in a HARP if they're already in managed care, and what it all means. So we're kind of in the end run here, the last stage of trying to make sure that everything goes as well as possible. I'm sure there'll be some glitches. We're going to have a hotline and other things available for people to contact us if things are not going well. And we're going to try to make this as successful a transition as we can. Again, the ultimate purpose here, I think, is a really good one, that we really do get the kinds of services that individuals need into the Medicaid benefit, peer services, employment support services, et cetera. So we're really very excited about it, but a lot of the stuff in the beginning is making sure the providers get paid, making sure the bills are paid, making sure that the registration goes well. One of the areas which we're still ramping up, and we might not have as many people enrolled in health homes as we would have liked to before the start. We're still trying to ramp that up over the next few months. We probably I think about 25% maybe. We're getting close to 25%. That's too low. We'd love to have 50 or 60%. So we're in the process of getting to both providers, the health department, and the plans to try to ramp up the ability to get the enrollment in health homes, because everybody knows you got to be in the health home to get the care coordination, which is a critical piece of the whole. So there's a number of things going on, and we're going to be working with providers and managed care companies to try and move that along. Certainly any feedback we can get from you or from the communities will be very important as we go forward and try to make sure that this goes as smoothly as possible. The other piece of notice, which I think, and actually Rob will talk more about managed care too, but we are going to be applying, I think everybody knows, for the Certified Community Behavioral Health Clinic Grant, which is the federal grant, which is setting up pretty much the equivalent of an FQHC for behavioral health. It's a grant that begins with planning grants. They're going to probably be funding 25 states with planning grants, up to $2 million to plan. Then after that, they will choose 8 states to actually implement the program. So we're going to be going for the planning grant. It's due in a few days, August 5th. We've done it jointly with Oasis, and Rob can talk to a little more about that. And I think we're pretty hopeful that we're in a position to do probably pretty well in terms of getting the planning grant. Now, the planning grant is interesting because as a result of the planning grant, if we get it, we have to pick a number of sites across the state that will be, we have to be at least two from 2 different areas in the state. We may be going for more. I think it's 5 or 6 that we may be going for in the state. And that those sites would be required to have all the required services, and this is a very hefty lift. The required services include a whole host of behavioral health services, including clinic services, comprehensive coordination services, a 24-hour, 7-day-a-week crisis team that has a 3-hour response time, and a whole host of addiction services, Oasis services as well, in one place or contracted with them closely. So the sites that we're going to pick, we haven't decided yet on what those criteria are for who would be applying and how we're going to exactly do that. That'll be part of the planning grant if we get it. But it's going to be a lot of work for the sites, both in getting the services up and then the methodology as to how to pay for it. The big push of this is to have basically a cost-based model similar to the FQHCs. But we in New York State are be working closely with CMS to see if we can also tweak that a bit to fit into the new value-based purchasing approach, which New York State is going for. So we've had some preliminary discussions with CMS, and they seem to be on board with that. It will still be a prospective payment system based on cost, but we're probably going to, around the edges, work on it having a value-based purchasing component. So There's a lot of work to be done. I think it's a very exciting program. I'm pretty sure we're very hopeful that we will get the planning grant, but we have to do a good job with the planning grant if we're going to get the grant to expand it to the rest of the state.
Is that for kids and adults? Or
Yes, as far as I know, it's everything. So it's kids, adults, everything, right, Rob?
I believe so, yeah.
Yeah, so it's really comprehensive. So the places we pick have to be up for this over the course of the year, or we won't get the full grant. And there's been a lot of interest, but I think the complexity of it is something that people have to appreciate. So who eventually works with us on this has to be up for pulling together a big program and having it really well coordinated if we're going to be able to be successful in getting the grant going forward. One other quick thing, I just wanted to let you know that we had gotten a suicide prevention grant a number of months ago, not years, what? And we're actually in full swing now in Monroe County and Erie County and trying to set up the services that would provide, it goes along with the zero suicide prevention approach, which is to work with high-risk populations. And it involves very intricate safety planning and acute follow-up after individuals are released from a psychiatric emergency room. So in addition to doing it at a couple of sites that are funded by the grant, we're also setting up a collaborative across the state. And we're hopeful a number of especially EDs and inpatient services will work with us on setting up a similar approach. It's a kind of evidence-based approach to actually following up after someone has made a serious suicide attempt. And I don't think across the state we have it down really tight how we approach those clients when they enter into our emergency services system. If we can get it working on the psych services system, then I think what we will probably do is try to put up a collaborative to work on this in the medical emergency rooms too, because there's a number of individuals who get discharged from medical emergency rooms, and the follow-up out of both systems actually, both our ERs and the ER CPEPs and psychiatric, with a lot of psychiatric emergency room and medical is not the greatest. And these are individuals who are very high risk because, as we all know, one suicide attempt is a large predictor of possibly a successful suicide down the road. So that's something exciting that we're looking at, and we're going to try to see if we can, again, eventually make the model something that we can do statewide. Just to bring to your attention the K2 problem, and probably Rob will talk more about this, but in our state psych centers, I think it was last week or a little bit before last week, 5 individuals from one of our state psych centers got admitted, 3 of them to, again, an ICU for kind of using various K2 that you get your hands on from various small shops, bodegas, et cetera, across the city. There's also happening upstate. We're doing a lot of education with our patients, trying to help them understand just how dangerous this stuff is, but it seems to leak very quickly into the system. A number of people take it or use it. The autonomic effects, the high blood pressure, et cetera, is very acute for some and can look very, very serious. Thank God so far it's cleared pretty well with support. But for patients, I'm concerned are if they have serious medical problems or on some of our medications. I don't know if we'll be so lucky all the time when these crises happen. So we're in the process of trying to deal with this on a clinical level, and I know the Department of Health knows about it, in the city, the Department of DOH-MH. They're talking with the police, et cetera, but it's a growing concern, and probably Rob can talk about it. But they seem to be targeting in certain areas our vulnerable populations who live in residences and who seem to be very vulnerable to picking up these drugs and starting to use them. And then lastly, and I'll send this one over to Rob especially, we've had, I think, 5, how many forums? 5? On the study integration, 3. We've had 3 forums on the study integration, and I think that they've been very informative, actually. I think that they've taught us a lot. We're hearing from the community. There have been good turnouts at all of them, and maybe Rob can talk a little bit more about that. And again, I want to thank you guys, because I know you were there for one of our first tries on this, and helped us understand how to go forward with the forums. So I'll end with that. And Rob?
Okay. Sure. Thank you, Commissioner. So I'll apologize for Commissioner Gonzalez-Sanchez. She's not in control of her schedule, and other matters were put on it today that require her to be at somewhere else. So she asked me to stand in for her. On the forums, yeah, we've held Albany, New York City, and Syracuse. All of them were full houses. The first 2, New York City and Albany, we did tape them. They're on the Oasis. I'm looking at Tracy YouTube channel, and we're working out some technical difficulties with OMH's folks being able to look at them, but they are on the Oasis.
Yep.
Because we said we would post them so people could watch.
They're also linked through the designated page through the OMH site as well.
Okay.
So you can get there either way, but there have been some glitches with some
Right.
people not being able to access YouTube that we're working on.
So they're available. I echo what Commissioner Sullivan said. I think they've been very informative. I think once we break the ice and get people interested in coming up and talking, they're doing a good job. We have 2 forums left, and I'll own the scheduling of these, but the 18th is in Farmingdale in Long Island, and the 20th is in Buffalo. So that's where I'm spending the end of August.
I love New York tour.
We're going everywhere, from one end to the other. But so, and we know already from registration, pre-registration, those are both going to be pretty heavily attended, which is exactly what we wanted. So that we will continue with those. The comments, I think, have been helpful. They'll inform us so we can inform the governor's office. And many of the steering committee members have done a really good job of attending. There was really good attendance at the Syracuse after having attended the previous week in New York City and Albany. So we appreciate that. I think it helps. And they've assisted us in actually drawing out folks in their comments and getting people to come up and speak. So we thank you. We appreciate that. Again, as we had pointed out, the page, which is set up, does have an email address that people can, and we've told everybody this all along, you don't have to show up at a forum to provide us with comments. We're receiving plenty of comments through the email address that we set up. So, we encourage everybody, try to participate at one of the events. If you can't make it, absolutely provide comments, your thoughts on that through the webpage and through the email address.
When's the deadline for comments to be submitted through the email?
We haven't set a hard deadline yet. I think we are looking to come back to the steering committee in September. So I would think sometime, end of August probably would be when we would still take comments, but the ability for us to then process them and start to put together some recommendations, we get challenged at that point. So, so that's been good. The governor has been doing Capitol for a day. He did it in Rochester on July 9th. Commissioner Gonzalez-Sanchez was there. There are more coming. I can tell you one of the she held a listening forum in Rochester, which she found to be very helpful. It was our providers, but it was also other leaders from other aspects of the Monroe County, Rochester community. It was helpful for her. It's assisting us as we try to move forward. One of the things that she announced, which is a system-wide issue, is we've put out at Oasis an application process for our opioid treatment programs to be able. They have certified capacity. We will consider at this point, especially with the epidemic of heroin and opioid abuse that we're dealing with, lifting their capacities. They need to make an application. It's very simple. But I can tell you one of the things we're looking at is a commitment to running the program like any other healthcare facility, setting up appointments, not having people waiting in long lines to get their dose of methadone. We want it to be much more patient-centered. And we're also looking for providers interested in doing this to buying into using other medications for addiction beyond methadone. So that has been put out there. It's well received. We look forward to working with our OTP providers to make that happen. I want to give you a heads up. The commissioner and I, this Friday, Michael Botticelli, who's the director of the White House's Office of National Drug Control Policy, has asked Commissioner to speak about what we're doing in New York with our move to Medicaid managed care, how we've implemented the federal parity law, the Affordable Care Act. So I believe Pat Tracy Wright will send out some information for the council members.
Sure, absolutely. We'll send
Because
out
it's
the
an open
details.
WebEx,
Yep.
a nationwide WebEx. So we'll get information out on that. Couple quick updates on RFPs. We've issued an RFP to create up to 80 new units of permanent supportive housing in New York City through the New York 3 agreement. Actually, yeah, well, it's done. So we've received the proposals and we're reviewing them. We put out a procurement to create community residential services in Richmond County, where we've been dealing with a pretty significant issue with the heroin and prescription opioid abuse. And we have a youth clubhouse RFP or planning supplement. We would work through the counties on that one. That is out as well. On the K2 spice synthetic marijuana, just by the way, it's not marijuana or synthetic marijuana. They market it that way. It is concoctions of chemicals. And quite honestly, the chemists are way ahead of the testing. Most of the ways we're finding out that that's what people were using is by the packaging that we can get from them. It is an issue. It's interesting because it's crossing all the systems. People are showing up in emergency departments appearing to have some type of psychotic episode. They're showing up and they seem to be targeting OMH residential facilities, correctional facilities as well. Westchester County had K2 snuck into their facility and had 8 people end up going for emergency care. So we are, one of the things that's already been done by the state, the Department of Health has put out emergency updated regulations to add compounds that we've been able to test and find because we're trying to catch up to the chemist. The other thing we are looking at is potentially moving to an approach that will bring law enforcement more directly into this by defining certain of these compounds as controlled substances, which then makes them subject to penal law, possession and sale provisions. It's a work in progress. We have been looking at it since the end of the legislative session. I would say stay tuned for something potentially coming on that. Our view is we really do need to engage local law enforcement to get them to get these products out of these shops and off the street. So that's that. The Medicaid managed care, as Commissioner said, we are full bore ahead. I think we're sort of, we want to call it the finish line for half a second, but it's really the starting line as well. But I think, credit to all the folks who've been involved. I think we've spent, it took us the amount of time it took us to design a system that we think will be good for our patients, good for our providers. OASIS and OMH have been really careful about making sure we protect our systems through what's going to be a really significant transition. One OASIS specific thing, as everyone knows, we're going to get approval to redesign our residential system with CMS and with Medicaid participation for the medical clinical aspects of those services. We are working through the Managed Care Technical Assistance Center. We're going to be doing continuous updates. We're going to do some pretty quickly here, folks focused exclusively on our residential redesign. It's intended for those residential providers, but also for the Medicaid managed care plans. So stay tuned for those. They're coming up. Other than that, we're sort of sitting back and relaxing. There's not much going on this summer. So those are the OASIS comments.
Okay, that's great. Terrific reports. Thank you very much. Let's open it up to any questions from anyone on the council in any of the 3 locations. And if you're in Rochester or Albany, please don't just put up your hand, but also say something, because I'm not the CEO.
I have questions. This is Stephanie.
Go ahead, Stephanie.
So I have a couple. First, the suicide prevention grant. Are there peers involved, and is that also across the age span?
It's just for adults. That's the way the grant was written, so we're kind of locked into it. It was the high risk. It's for adults in the high risk range of, I think it's the late 20s to 50s with the highest rate of suicides, adult males, but it's in the more of the adult range. It's not, unfortunately. I don't think that they have, the model that they proposed doesn't involve directly peers as part of it. And I think that that's something it's a good suggestion, something we'll look into as we do our own collaborative, which doesn't have to follow exactly what the grant, was asking us to do, because they have a particular model that was part of what they expected with the grant, which doesn't directly involve peers.
Right, and I think that for hospital-based, especially with Monroe and Erie, where you do see peers working in the emergency rooms and things like that, it would be a natural build to have maybe the peers help follow up, which I think is a really excellent piece.
Maybe
Am I not talking loud enough?
Yeah, maybe you can speak up a little.
Sorry.
This is Maura from Buffalo, and we are working with Buffalo Psychiatric Center, our peer agency, to work at the county hospital. So Buffalo Psychiatric Center is involving peers in this research study, in this research grant proposal.
Excellent. Thanks, Maura. Okay, so my other question was, is there going to be a K2 awareness campaign for the public, not just necessarily providers and police officers, but just general youth and adults that are maybe thinking that this is an okay, not realizing the potential side effects?
Mm-hmm.
Yeah, I mean, as we're exploring how we get the product off the shelf. Well, it's not even. It's off behind the counters. They're not out on shelves. They're hidden behind the counter and ask the right question and they pull it out. But yeah, I mean, we've been looking at Oasis, because our whole Combat Heroin campaign, right? We did it to start there, but the reality is nobody starts with heroin. It starts elsewhere. So we're trying to broaden the message to be more about combating addiction. And so we are looking at how we can do a better job of educating. One of the things I will tell you, one of the legislative ideas we're looking at is creating a website that DOH, DCJS would operate, where we would put information out about what we know and what's out there. So we would use that as well to try to educate the public. So we are looking at that aspect as well. Because I do think people don't understand. These are much more dangerous, significantly more dangerous. They are hurting people. So, yeah, we are looking at that.
Yeah, and like you said, the misconception that it's synthetic marijuana is really dangerous because people have a conception
These are chemical
of
creations that are having really significant health, are causing really significant health issues for people.
Right. Okay, one last one. And that is with the Youth Clubhouse RFP. Did you require that peers have to be involved in the design or implementation of that?
Yes.
Excellent. All right, thank you.
That's what's going to drive those, quite honestly, is kids. The model that the commissioner, she was at a national meeting, Georgia has tried this, and she was really impressed with how they had made it work. And it drives off of kids really driving this concept. So yeah, absolutely, peers is an absolute essential part of it.
Excellent.
It's on our website too, so you can look at it to see where we were going.
Thank you.
John here in New York.
Hi. The topic is the value-based purchasing initiative that's being driven by DOH. I guess I have a concern that as collectively as a provider community, we're somewhat behind the eight ball in terms of being able to participate in value-based purchasing and succeed, because in many cases our providers, we don't have the kind of infrastructure in place to capture the kind of data that would be necessary to demonstrate, for example, participation in shared savings and some of the other aspects of value-based purchasing. And I think we really do need the state agencies to help us as providers. Some few of us are at the table in some of the work groups. It's fairly technical. It's clearly geared around managed care payers and hospitals who really, have the greatest experience and infrastructure and capacity to enter into these kinds of risk arrangements. There are all sorts of technical issues related to, reserves that you might need and tracking systems and EHRs and, and analysis. So I just think that I really ask both agencies to really try to, be advocates for helping us to be able to, come to the table and participate, whether it's through HCOs or IPAs or all these other entities. Ultimately, we're responsible for our agencies, and even a fairly large agency like ours has not the infrastructure as compared to a hospital. I think in terms of, even if we had the dollars to build up that kind of capacity, we also run into the EO 38 limits on infrastructure and overhead. I would ask that there be some recognition that we need these kinds of expenses counted as program expenses rather than indirect expenses. I mean, I think there's a lot of aspects to this. I can go on, but I would just ask that the agencies try to be at the table, help us. I think there's probably money that's needed, there's technical assistance that's needed, there's advocacy for our provider community so that we can, continue to deliver services and as I said, get credit for the ways in which we do, in fact, add value to the system and produce, the hospitalizations and other untoward outcomes for clients. So just a question and a concern, but also I think an opportunity for us to kind of advance our field.
Yeah, I think what you say is absolutely right, and I think we've been talking with in the value-based work groups, which I agree with you are so far pretty technical and still at a relatively high level, with DOH about the importance of figuring out a way that the downstream providers, not just the big hospitals, but others can be involved in real value-based purchasing. Because what a lot of systems have is that, let's say the hospital takes risk, but they basically pay after that, or whatever the agency is, the big thing takes risk, and after that they pay out on basically a fee-for-service basis. And that's not real value-based purchasing, and I don't think that's what the state is really looking for. But it gets complicated, and I think it's probably not going to be very easy for individual many of our Article 31s to do this alone. They're going to have to get into relationships with other group, either hospitals or other big agencies coming together and sharing some of the, whatever the bonus payment might be for value or case rates or bundled rates. And we're in the process of beginning to talk with DOH about what some of those bundled rates be, like what might be a bundled rate for depression and what that look like, and what might it look like that you would get paid for on the hospital side, what might it look like that you would get paid for on the community-based side. And so we're in the beginning of looking at this. I also think the first 2 years that we're into managed care is the time that we're going to start looking at these kinds of models and incorporating it with, the Article 31s and the other clinics to figure out how we work with the managed care companies. So it's not just a fee-for-service phenomena out to those providers, but that they share in some of the good work that they're doing and some of the savings, if there are some. So I think that we've got to work that out, and I think innovative models for doing that is going to be a really big objective, to work with certain people to get models going in those first couple of years so that we're not expected to do it all of a sudden. I think you're absolutely right. And I don't know that there's a lot of it, despite the fact that everybody says, we should just do value-based purchasing. We've been trying to find places that have done this, really moving it down to and there's not a lot of evidence of a lot of people having done it yet. So some of it is unmarked territory, to tell you the truth. So I think we're going to have to work at it a lot over the next couple of years. And you're absolutely right. It has to be out there with the provider community as to what this might look like.
Yeah, and I think exactly. Because otherwise, we're just getting discounted fee for service, and everyone else is taking the savings.
And we don't want that, because that will ultimately diminish the ability of you guys to do the kind of work you do. So we're pushing very hard with DOH to say that that's not acceptable, that we have to have some models here that can really involve the whole team in getting something out of whatever value-based purchasing is and whatever savings there might be.
Yeah, I would just add, it's consistent with what we're saying with DSRIP as well, is that DSRIP, the goal isn't achievable without community-based behavioral health providers being intimately involved. And so that involves not just then being in the PPS and doing the projects, but it involves them being rewarded for the outcomes that come from good interventions from the providers, trust that we are advocating. And part of the advocacy involved drawing many of you into the various committees that are being set up. You know, the other thing I would say with regard to EO 38, remember there's ability to waive on the percentages for cost. And, you know, when EO 38, the regs implementing it were written, you know, we weren't thinking about value-based purchasing or DSRIP even. So if there are legitimate reasons, I would like to think that we and Division of Budget would entertain those in terms of issuing waivers on expenses and costs.
This is Sherry. I have a question. Is OMH planning to put together a level of care determination instrument similar to what OASIS has?
We haven't really gone to that yet. No, I think that we're looking at what OASIS did, and we're looking at what might be, what might be possible. Many of the managed care groups and stuff have things that they've been using, so we're looking. But no, we don't have a specific plan at this point in time to do that. We have what we're using for the assessment is for the HARP is the inter-eye, which gives a certain uniformity across the system with DOH, but we haven't really looked at that yet. No.
But just know though that with any kind of instrument that a plan is using, it's subject to OMH's approval, just as on the others are. We just decided that to go the course we did. Some of it was driven by the legislation that was passed, in 2014. But plans are not going to be sort of making up the rules here. That's been one of the fundamental
thanks, Rob.
issues.
Absolutely. We're reviewing everything they're doing, and we're going to be looking at it, but we haven't come up with a uniform one, which we're saying this is what everybody has to adopt. No, we haven't done that piece. But yes, we are looking at what they're doing. We're going to be looking very closely. Thanks.
I have a question. This is Maura in Rochester. Commissioner Sullivan, you talked about the Medicaid rollout. Does this include the rollout of certified peers being billed?
Yes.
Being able to bill?
Yes. Yes, so certified, so we're going to, hopefully we will have ready the ability for that billing to happen. However, just so everybody's very clear in the peer community that for the first year, we are not decreasing the dollars that are going for the current peer-related services, for example, that have never billed for Medicaid. All the state funding for that will continue for the first year so that we can get really clear indications as to how much of what we do is really billable, making sure that the ability to bill is okay. Then what we will do for the second year is say, okay, in the first year after all the years ended, and we find out 30% of what you've done is really billable and we've got it all in place. In the second year, we would decrease the funding that we give by that 30%. But I don't want people to get angry. For the first year, let me just say point blank, you're covered. But the first year is our learning period to understand how we're going to do it, especially in those services that are grant funded. Now, the pros billing and the billing for other things, which we've been billing through bundled rates and stuff, but haven't been going through the managed care system, that we're hoping that we can get in place by October 1st and get that billing online so the provider gets what they need, and that basically there's no glitches. That's what we're concentrating on. The peer we're going to begin, but we also understand there's a big learning curve here, and we're going to keep everybody fully funded for the first year. So I just want that out there, and probably for the second year too. But we may not give you the full funding if you're already billing for it. We can't double pay. We can't double pay, obviously.
Does the first year start in October?
Yes, October 1st. Right. Mm-hmm.
Okay. Thank you.
I want to bring out the topic back to the K2 issue. I'm glad there's a lot of focus on this. When we first brought this up about a year and a half ago in this committee, we thought it was a crisis then. Now we realize, particularly in the residential community, what a crisis it is. I think it's the biggest crisis I've seen in 30 years in running residences. And Rob, you touched on the law enforcement, and I think we're doing the education, we're doing the addiction services, but I really do think we need to do more on the law enforcement side. And you mentioned the local law enforcement. They tend not to focus on prevention. They come and they pick up the pieces after somebody gets violent, gets sick. And when we presented here, we brought in the state DEA, I think it was the
Bureau of Narcotics Control, I think it's DOH.
Right. And I'm wondering if there can be a focus. I believe that investigators need to go into our residences. We're over a dozen people are buying this, doing it on a daily basis. I've got staff who are resigning because they don't want to be in a building alone at night with people that are smoking this stuff. And I'm just wondering if we can't do more on the law enforcement side and state outside of OASIS and OMACE, the enforcement side can come into our communities, interview our residents, walk around to the bodegas, ask questions, talk to the local law enforcement people, and I just think, there's no clear solution, but I think we could be doing more in this area.
Yeah, like I said, we're focused on it. The current regulations of the Department of Health are they're violations. So some of it is getting local law enforcement interested in that aspect. And one of the things I would say to you is, I think we are looking at some additional legislative solutions to add a criminal penalty aspect to it. And as much as we know it's an issue here, it would be really helpful if you communicate to your legislators to let them know that it's an issue in their communities, just like people did with heroin and prescription opioids, because I have to tell you, they weren't as interested, maybe, as I'm trying to be polite here, in the issue as we started to talk about it at the end of the session. So I would encourage some education of state legislators on how pervasive this is right now in the behavioral health world. I think it would help us in some of the other things that we're trying to do, which are really focused in on trying to get this stuff off the streets.
Yeah, and I think in the city, I know that DOHMH is trying very hard to work with the city police department on this issue, and I think that there's been some variable responses across the city in terms of even of how to approach it. So I think, again, I would get your comments very clearly to DOHMH as well, so that they can kind of give it forward to the police department. And they are working better with us now in terms of looking at it. And the state is trying, they're really looking at trying to figure out a way that they can make, as Rob is saying, some kind of criminal responsibility. The trouble is they change the compounds overnight, and it's like, this one's illegal, but is this one illegal? And what makes it illegal and what doesn't make it illegal? So it's very hard for them to kind of figure a way to get a handle on how you're going to prosecute somebody for this stuff. Right now they're saying basically you can't sell it, but it's not, doesn't have a lot of teeth to it. So, but I think, banging on the door, go to DOHMH, go to the police, go to them and ask them to go to the police, go to your legislators. I think that we're trying to raise awareness as much as we can within state government, but I think it helps for others too to keep raising this. I agree with you. I've never seen this kind of approach. It's like somebody really got the idea that they can go into the residences and get people to kind of buy this stuff. And there's always been some stuff going on, but not like this. So this is new, especially in certain areas. The city, certain places upstate as well, have had a very similar kind of experience.
No, thank you. I think last time I remember something as severe was when we tried a vegetarian diet for a week.
I get it.
But I do think this is an MRT issue as well. I would say a large percentage of our hospitalizations now have to do with K2, and maybe we should look at some MRT dollars focused on this issue.
That's a good point, actually, yes, because this is costing the system, a lot of money.
That's funny, as Ralph began to speak, I was getting ready to ask a similar question and wanted to thank Ralph for bringing up the information about the law enforcement with the K2. One of the things for years, in our treatment setting, we've been such a proponent of treatment, and we have now begun to start seeing people come in and preying upon the people receiving the treatment. So people are coming in and attempting to, right on the premises, they'll try to sell all kinds of things. It's not even just K2. You're getting, all different types of heroin, different things like that. And in the past, we didn't necessarily say, well, let's bring the police in. This person is just as sick, and this person is using. Let's put them on detox. But now there's this real push from our team that anybody who does this, that law enforcement needs to be brought in and have it put to their attention that anybody brought in violation would actually be subjected to arrest. And when I was a little hesitant for a while until I saw the news about the Westchester County Jail and how they arrested all of the people who had given the drug, the case spice, to the other people. They actually they were already in jail, but they trumped up their charges even more. And I thought about, we had just had a big meeting about this at our building as far as do we bring in law enforcement when we find this happening? And I believe that is really more of the push for us. And I know there's nothing in our regs that actually talks about it at all, that talks about any of the, if people, what do we do if we have those types of occurrences in our programs. And I didn't know whether that was something that we wanted to think about later on down the line. If there is a crossover between the criminal justice and the agencies, if there's something that we can do. I have developed a relationship with our local sheriff and our chief of police for us to have drug sniffing dogs come on. But they said if they came on and they found something, that they would arrest the people where it was found. And so there were certain things that we weren't sure about what we could, what our parameters were. But I do think that we need to send a message from the provider communities, from the treatment programs, that we are no longer going to allow these things to happen in our residences and our treatment programs, and that we take a stand somehow. So, I don't know if we can do something more as far as that voice with the criminal, justice population. I do believe in treatment, but I do think that there are some people preying on our people who are trying to get treatment, and I wanted to say something about that as a quarter ground.
Yeah.
One of the things that we have a rather large facility up in Elderville, a 228-bed facility, and to address this problem with law enforcement, we actually hired a private company that will endorse. Might be a way of being able to.
And when you find it, what do you do?
We discharge or take action on people that have their possession. But at least it doesn't result in arrest. I mean, I'd rather go after the people that are actually selling the stuff, frankly. But we've been able to do that.
Let's say we found people that are trying to sell.
So, yeah.
This is Stephanie in Albany. I just, from a personal perspective, I just kind of have to say something that, it bothers me a lot to think that the way that we're going to prevent this is by feeding people more into the prison industry, and that, I think that we should be educating people. And maybe I'm overstating this, but, I look at how bath salts made the news in terms of then in the youth community, it wasn't all of a sudden everybody was wanting to go do bath salts and risk eating somebody's face off and act like a zombie, and that's how word got out. That's dangerous, let's do something else. And maybe still there's people doing it, I don't want to generalize but it's not as common as hearing what young people and people in my peer age range would say about K2, which is, oh, it's just a synthetic marijuana. And, marijuana is becoming legalized across the country. People have an acceptance, tolerance of it. And so just to talk about how people are ending up with psychotic breaks is really important because, people in these programs are probably thinking that it's not illegal, that they're not going to get in trouble. And so it's accessible to them. And then here we are just as the penalty, when they're already in a program, and like you said, vulnerable people, we're going to move them into a law enforcement realm. That really bothers me, and I think we need to do more than that.
Differently, I'm not talking about people who are using. I'm talking about people who are with intent to sell to people who are vulnerable. And I do think we have some of those folks that are actually attempting to capitalize on the people that are receiving treatment. The people who are going through. I would, if I found a person who's intent was to use themselves because they're going through something, that's one thing. But if their intent is to give it to other people, and that could, we've had people who actually died because somebody else gave them something, and there has to be a message at some point. I just have some concern. I'm torn because I've been through this for years and I've never done that. I've never thought about the legal, taking from a legal standpoint. But I'm at a stuck place right now because I'm seeing it happening. The sophistication of it is happening more and more. And what message are we sending to the people that there's no level of safety of the services that they're trying to receive? Where do we go at that point?
Absolutely, and I think that this is a much bigger discussion that I hope we have, because I think that, we can't have, people living in poverty in these institutional settings that see an opportunity to make some extra money, that don't necessarily know the consequences. We need to make sure that we're making a public effort to, one, engage the media, and two, make sure people know about, as consequences come up, make sure that they're that's a public awareness campaign. Because I just feel like we're taught, you said it when you said they're vulnerable people, and it's very easy when you are in a community residence and somebody approaches you, hey, do you even want to sell this to the other people in the residence? You can make some extra money, you just don't necessarily think it's legal. So I think it's a slippery slope that we really should be careful about, because these are vulnerable people.
Thanks. Dr. Brown?
Commissioner and Rob, I do appreciate the efforts that you two are pursuing with respect to this clearly public health issue. Dr. Martin and I have brought this up with the Commissioner of Health as a Public Health and Health Planning Council. It does appear to me that there is a need to have a more effective collaboration that includes not only on the care side, but quite frankly, I think it does need to include on the supply side the issue about law enforcement. Would there be a receptivity to members of this council drafting a sort of a process, a document, to help to facilitate and demonstrate this council's real concern as well as a willingness to be a part of the seeking the solution that is clearly going to have to be more complicated than what we initially thought. This is Commissioner and Rob.
Well, to us, I think that would be great. I think that it would be very helpful, and I think it would come forward, and I think it could bring up the kinds of issues of making sure that, that how do you enforce it? How do you kind of educate the importance of really getting the word out there? The serious consequences to our patient population, and also where do all these kinds of things. I think it would be great. I just think it would be great, and I think it would put forward the voice of a bunch of experts sitting around these tables who say that this is a really serious problem that has to be paid attention to. I think it'd be good. Bob?
No disagreement here.
Howard?
Yeah, again, a question for the Commissioner and Rob, and once again, I echo, it's good to see that this is on the agenda, but my question is, what is being done at the OASIS and OMH level to lobby the legislature about what's going on in their communities as a general approach to build their awareness of this issue? Is there anything being done at the sort of higher level interaction between your agencies and the legislature in Albany?
Yes. Without details, absolutely.
Okay. Well, I think is that I saw a lot of heads nodding at Dr. Brown's suggestion.
But I would just like to, if I could just add, though, legislators' biggest response is when the communities go directly to them.
Right.
So the other thing I think that those of you who have legislators, in addition to if this is written by the council, I would bring it to your legislators, because while we talk with, we're still government talking with legislators. I tell you the strongest voices with legislators are their community members, and so bringing this up to them from that route would be very helpful.
An excellent point. Of course, once if we draft a letter, send it. That's a public document. People can do with it what they like.
Exactly.
Paul, Jim Scordo, just one more comment.
Sure, go ahead.
As we're doing this, I think it's also an opportunity to include in this about the opiate and heroin epidemic. I think that that could benefit, our communities can benefit from education about that as well. And this K2 certainly presents some challenges, but we also have this opiate heroin epidemic that is out there, that it's an opportunity to include that in this message.
Well, yeah, and to that point, I mean, we've been talking, as I talked about the Combat Heroin campaign, you know, we're trying to broaden it because it's really more about addiction. And like I said, nobody starts with heroin. They start elsewhere, and now it seems like synthetics is one of the places people are going, and you can buy it in a store, right? It's not like it's being sold on the street corner, so, well, it is, but it's also behind the counter at a store. So, yeah, we are doing that. I mean, I will tell you, most legislators are completely familiar with the heroin opioid issue, which is why they've been supporting our efforts and passed the bills they did a couple years ago. But I will tell you from firsthand experience, I don't know that they're as knowledgeable right now on this whole synthetics issue. So to Commissioner Sullivan's point, we would really encourage you to make them aware of what's going on from your perspective in their communities as it relates to these synthetic drugs.
This is Scott in Rochester. I mean, given the rapidity of how these things come to market so quickly and how they disappear so quickly, I think what this points to is that there's really probably a need for a concerted effort around an emerging drug and to form a work group towards that effect. That group could, identify new drugs as they emerge with intelligence from law enforcement, treatment providers, prevention. You could look at who's being affected or targeted with these various drugs, any geographic distribution across the entire state, and then you could propose strategic intervention strategies, because I don't think we're talking about it necessarily a statewide kind of effect. There are regional differences with some of these, and I think having a group that focused on looking at that would probably be very beneficial.
So to wrap this up, since we do have to move on, so I think so maybe what it would make sense to do is that if those of you who have spoken on this issue, and anyone else who wants to join would be willing to participate in maybe in a conference call, I'd be happy to join it. And we could sort of talk through what might be something that would be useful coming out of the council. So, seeing some heads nod yes here, so if I can, draft, Ralph, Dr. Brown, Patrice, Stephanie, I don't know, Scott, if you want to join, or anyone else. I'm not actually drafting anyone, I'm suggesting. So, whoever wants to join that, so maybe Ralph, since you brought it up, one of the first people brought it, maybe, if you want to just, be the coordination coordinator, we'll work with you, we'll set up a call, and actually I think we'll invite anyone on the council who wants to join that call. And that's the way we'll move forward. So really terrific discussion. I think a great idea for us to produce something to sort of lay out here what our concerns are, and some ideas about what the state can do. So thank you all very much for that. I'm just going to throw one last question out, and then we'll move on, and that is, Rob, I didn't want to go by without making a comment about the exciting development that you mentioned about residential redesign. Including the letter that CMS just issued, stating very clearly, stating explicitly that they will be looking favorably at requests for 1115 waivers to test out new approaches, including those that may be currently prohibited by law, such as Medicaid funding for IMDs. Clearly a result of the real pioneering work that New York has done along with a couple of other states. So that's very exciting. I don't know if you have anything to add about timetable or anything, but just wanted to make mention here about how, for someone who's been working on this issue for over 30 years trying to get Medicaid to pay for residential services, how exciting this is.
Yeah. So the CMS issued a state Medicaid director's letter Monday, I believe it came out. effectively saying that they will consider states who submit 1115 demonstration waivers the ability to pay for certain types of services that otherwise they would be precluded from doing. We in New York have been all throughout, as we've been doing Medicaid, the move to Medicaid managed care, we've had as part of our plan, not that they would buy our residential services, but that the Medicaid managed care plans could buy medical clinical services in those settings that are otherwise reimbursable in every other setting. So we're taking a little bit different approach. To the extent what we put forward helped push that letter to come out so that all the other states can take advantage of it, so be it. But I mean, we pretty much have, we're dotting I's and crossing T's right now with CMS on, when they issue approvals, it's called the standard terms and conditions letter, and we've had this issue sort of resolved with them for a while. So we were heartened to see the letter sort of confirming what we had already been doing. So yeah, we think it's a good thing. The SUD system, with everything that's going on, with state level reform, with the Affordable Care Act, residential services in the SUD system are an essential part of the continuum of care, and to let certain rules or ways of doing business get in the way of that would just completely compromise the whole system. So I think we took an approach that they found acceptable, or that they've indicated that, and so the letter is reaffirming, and I think it's a good thing for all the other states to have that opportunity.
Great. Thanks very much. Thanks to both Ann and Rob. Very much appreciated. Let's move on to the agenda. The next item is the Regulations Review Committee. Patrice.
Hi, we have 4 regulations to review today. All of them are from OMH. 2 of them are relatively easy. One of them is medium, and the 4th one is not hard. It just has a lot of information. So I'm going to ask the OMH staff to assist me with presenting them today. I'm going to do the That Was Easy one first, and there's a public access to records of the Office of Mental Health, and basically right now there is an attorney and general counsel that actually is in charge of this. So just in keeping with the language of the regulation, this is really a cleanup. Instead of being a public information officer, there's actually a lawyer in the office who is designated to do this. So that was the only recommended change for that regulation. And those of us in the committee don't have any problems with that information. The next one was referencing personalized recovery-oriented services. And Liam, are you there?
Yes. Yep.
Okay. Do you want to talk a little bit about this?
Sure. The ORS component in the PROS model is the Employment Support Services component. And there was a statement we had that fell out of the regulations in 2012 when we modified the regulations. And what we're proposing to do is reinstate the statement that requires programs to complete the psych rehab assessment only for individuals who are only enrolled in this one component, as opposed to being required to completing all 5 required assessments that most other participants need to have completed when they're enrolled in all 4 components of the model.
Needless to say, the consensus was anything to reduce paperwork is a thumbs up. So that was another That Was Easy button.
Motherhood, apple pie, and
the next one was also referencing PROS, and it was a little bit about the medical assistance payment for outpatient programs. And Bob Law is going to talk to us about that.
Thank you. Yeah, I'm here, Patrice. And actually, the package is more than PROS. The package that's before you in reg changes involves changes to any of the Medicaid fees for OMH outpatient programs related to implementation of part of last year's budget, actually, which provided funding for certain salary and salary-related fringe benefits for direct care staff in programs. So this package will adjust the fees for PROS, Children's Day Treatment, partial hospitalization, CDT, and IPRT mental health programs. There's also a package pending at Division of Budget to increase the APGs for Article 31 clinics, but those fees are not in regulation, so you don't see those regs before you. Last year's budget action included this funding for certain associated with certain staff in those in mental health programs as well as other human service programs. So the adjustments in the regs are us making the adjustment related to direct care support, and then ultimately clinical staff as reported in the provider's consolidated fiscal report from 2012, and then applying it to the existing fees so that we can implement it for these particular programs.
When are they effective? Retro?
Well, anytime you want to give us less paperwork and more money, we like that.
Yeah, Mr. Getman asked the question, effective date. These will be effective April 1 of 15 once they're approved by Division of Budget. The packages are with Division of Budget now, and based on emails and phone calls over the last week, I'm expecting that they will be approved in the very near future. But we do need the regulations to go along with that to give us the authority to put those regs into EMEDNI. Or put the rates into EMEDNI, I'm sorry.
We did note that there was one kind of typo where you see level 4 on the first page and say 68, you really need to see 11. So other than that, everything else was fine, and we had no problem with that.
The other thing I reminded, or I had advised Patrice of, is one of the components of the statute required providers to respond with attestations to the various state agencies, including OMH, that they were using the funds in accordance with the statutory requirement. Since our fees, as contained in these regulations, are either regional or statewide, they are not provider-specific fees. When we put these out, everybody will get them, whether or not they have returned a attestation. Our intent is at the end of the year, if we do not have attestations in hand, we will calculate the amount of benefit to a particular provider and will be issuing recovery notices to the Department of Health to take those monies back from the providers. So staff are beginning to look at who did we receive attestations from, and they will be contacting both our field offices and the providers themselves, reminding them that we need this documentation so they can retain the money.
I have a question about that. I'm not sure I quite understand that approach. That is that we're asking providers to now submit a piece of paper saying that I do, when in fact don't we have other mechanisms to see, like their CFR, to see whether they are? I'm not sure that I understand how this is in the best interest of public policy and the use of limited resources.
It's a requirement of the statute. We have to have the attestation in hand.
Statute. We need to help our legislators. Okay. Thank you.
Put that in our letter.
Well, Bob, it was one of the conditions, it was built into the cost of living adjustments, was that there's attestation. So,
I mean, I understand what you're saying. I do have to follow what the statute requires me to do.
Understood. Okay. Good.
All right. Thank you. And last but not least, there was
Patrice, this is Robin Goldman from OMH Council.
Hi, Robin.
Hi. I don't know whether you were reserving voting on all of the regulations until the end, but you should be taking a separate vote on each. So I just wanted to make sure that
that's fine. I just wanted to get through them, and then we'll do a separate vote.
Okay.
At the end, if that's okay.
Okay.
Only because there's so much, I just want to get through them.
Okay, that's fine. It's just a departure.
The committee recommendations. I want the committee recommendations. So on all three of them, and then we'll just do the vote at the end.
Okay, that's fine. Yep, it was just a departure from the usual, so I just wanted to make sure.
Yeah, I'm sorry about that.
No problem.
Last but not least is Julie's going to present some of the changes that have come about because of Justice Center language as well as incident management programs.
Have a good day.
So, did you read?
Hi. In the interest of time, I'm just going to explain what this regulation is and just highlight a few pieces of it. As a result of passage of the Justice Center statute a couple of years ago, the agencies are required to develop incident regulations that have to be approved by the Justice Center before filing. So since the time that the Justice Center became up and running, we've been functioning under temporary emergency regulations, and we now have the clearance and, in fact, the mandate to issue permanent ones. So that's what we are doing here. This is OMH's version of what we hope would be the permanent incident management regulations, which will be filed as a notice of proposed and go through the 45-day public comment period and then be adopted. It differs very little from the emergency regulation that's currently in place. There's some minor fine-tuning of some of the definitions and some of the definitions in the incident categories, but as a practical matter, there's pretty much no change that a provider would experience with respect to what they are already reporting as incidents and the process and procedures that they go through in order to do that. So in that sense, it's a pretty easy lift. There are two changes on page 14 that we received permission from the Justice Center to include, which I think providers will like. They're in section 524.8 and they're subdivisions E and F. This is on page 14. The first one enables OMH and providers to develop protocols to deal with individuals who may be reporting allegations that are a result of their symptomatology as opposed to something that really happened. The way that the law reads now and the way that the emergency regulations function is that mandated reporters, which includes custodians, are supposed to report incidents immediately upon discovery. Discovery means when you witness it or when someone comes before you in your professional capacity and tells you something that gives you reasonable cause to believe an incident has occurred. In the case of a patient that may report to a custodian that something that seems quite spectacular may have happened to him or her, what our custodians have had to do up till now is report that immediately, and then it becomes clear relatively soon that this is really a manifestation of a psychosis. During that time, staff are moved. A lot of work needs to be done to get this underway. And now we're going to be able to establish a procedure that in cases like that, you have almost a 24-hour period to assess it. And if you determine in good faith that there is no reasonable cause to believe that this occurred, you don't have to report it, though you have to thoroughly document it. If you do determine at any point during that 24-hour assessment period that there is reasonable cause to believe it occurred, then you can report it then. And at that point, when you make that decision that you have reasonable cause, that's when discovery would be deemed to occur. So that's sort of what that's intended to capture, and it will provide some relief to providers, I think, in that respect. The second one has to do with multiple, and I may have reversed these, but the second one has to do with multiple mandated reporters. Some of you might recall that the way the statute is written, and up till now we've interpreted that every mandated reporter who witnesses or learns of an event has to report it, even if there's 5 mandated reporters that see the exact same thing at the exact same time. That's contrary to the procedures that are employed on the child abuse side. And so now there is the ability, if you have multiple mandated reporters who witness it, if some of them have actual knowledge that someone else has reported it, they do not also have to, but again, that has to be thoroughly documented. I also wanted to highlight on page 23 what appears to be a new provision exists because it's not currently in the emergency regulation, but it has been a required practice since even before the Justice Center, and that has to do with special investigations. The Office of Mental Health has required special investigations on certain types of acute events, and I was asked by staff to incorporate that in the permanent, just as more or less as a reminder to providers that they're supposed to do it. However, I also make clear in this provision that in an instance where the Justice Center itself is investigating one of these incidents, which because of their acuity, it's likely they may, if they are investigating an incident, then you do not do a separate special. That can serve as your special when you get the results of that. So that makes a clarification. The Justice Center has something, you stand down and let them take it, but if they haven't, then a special investigation will be required, and is required right now on these types of incidents. But if you're looking at that section right now, you'll say, well, wait a minute, I don't see any list of incidents here, and that's because this version does not include that list of events. I made a revision last night that put those back in, so you'll see that in the actual notice of proposed. But again, it's not a new requirement. So that, with that, I'd sort of like to open it up to questions if there are any.
I have one question. Is there there may be, and I may have missed it, some estimated prescribed period of time by which the Justice Center completes their assessment? Because that could really handcuff a provider. And if that's not included here, we should actually make a recommendation to the Justice Center that there needs to be some kind of guideline when they're going to complete their investigation. Because otherwise, either the employer is going to say that the burden seems to be on the employee and then release the employee. If they have a union, then you're going to have a grievance. You know, this gets to be a mess. If they don't have some kind of guidance, well, this may not speak directly to this, but we need to keep that on the, you might say, radar.
Any other questions or comments?
I believe the law does require the Justice Center to complete their investigation within 60 days, but it's a staffing issue.
60 days.
That's what the law prescribes.
Okay. Thank you. Yeah.
Okay. So with that being said, we can bring these to the full committee. The first one, which was the public access to records of the Office of Mental Health. Does anyone want to give us a motion?
Second.
Just repeat the committee's recommendation is to approve.
Is to approve all of these.
Okay, so all of them.
Okay. We're going one at a time right now.
So all in favor, say aye. Aye. Any opposed? Any abstentions? Passes unanimously.
The second one again was the personalized recovery-oriented services that will have the input presented to everyone.
So moved.
Second.
Second. Okay. All in favor, say aye. Aye. Any opposed? Any abstentions? Passes unanimously.
The third was the rate increases.
So moved.
So moved, yes.
Second.
All in favor, say aye.
Aye.
Opposed? Abstentions? Passes unanimously.
And last but not least was the presentation by Julie as far as the Justice Center. Thank you.
Motion? Anyone?
So moved.
Okay, second?
Second.
Okay, all in favor, say aye.
Aye.
Opposed? Abstention? Passes unanimously. Thank you very much.
Thank you.
And staff, thank you all. Let's move on to the project review committee. Glenn Martin was unable to be here today, and he wanted me to extend my appreciation to Tino Hernandez for going to take over and chair today as vice chair of the committee. Tino, you're up.
Okay. We're going to start with FAR for Center for Discovery. Center for Discovery is proposing to establish a new 8-bed community residence for eating disorders program known as Credit to be located, was supposed to be located in Westchester. One of the considerations today is that they could not find, they had difficulties finding a site in Westchester that met compliance, and the applicant expanded the search to other counties. and they found a suitable location that's been identified at 3 Sunset Avenue in Coag, Suffolk County. We actually have a representative here from the program. This is a FAR that had gotten, I think, conditional approval before, with the recommendation to review the staffing plan. And the staffing plan at this point. The committee reviewed this and recommended approval.
Okay. Is there any discussion? Okay. Before we vote, is there anyone who has a conflict or disclosure? Okay. So, you're making a motion to approve on behalf of the committee.
Yes.
Is there a second?
Second.
Okay. All in favor, say aye.
Aye.
Any opposed? Any abstentions? Passes unanimously. Approved.
Can I suggest that they bring more people to support the application next time?
Okay. Next one.
Next is a proposal for a new sponsor and a new clinic. It's West Islip Youth Enrichment Services. They're requesting approval to become an MHL Article 31 sponsor for purposes of establishing a clinic to serve children and adolescents. It sounds like children, adolescents, and young adults, age 5 to 21. The program expects to primarily serve residents in the town of Islip, but will be open to the general public. The new clinic will be located in the town of Islip Municipal Building. I believe they're getting space there for free. And they have a history. They've been they were founded in 1987. Have a history of working with the Office of Children and Family Services. They actually run 8 after-school programs for OCFS. They work with the Department of Diversity and Education Department, primarily in school settings. In their programs in school settings, they do conduct assessments and referrals for drug and alcohol abuse and mental health services. The committee reviewed this particular project. The only concern that we expressed, that we think it's kind of more of a policy concern made by my colleague here, is that we're actually approving clinics at the time that we're also moving into Medicaid managed care. So that we're really recommending that OASIS and OMH really take that into account in reviewing these applications. They indicated, I guess, that they seem to be prepared to be able to move into that managed care environment. So we recommended approval.
Okay. Any questions or discussion? Does anyone have any conflicts or disclosures? Okay, so you're making a motion for approval on behalf of the committee. Is there a second?
Second.
Okay. All in favor, say aye.
Aye.
Any opposed? Any abstentions? Passes unanimously.
Okay, next is Charles Evans Center, which operates DOH Article 28 Diagnostic and Treatment Center, has also become designated as a federally qualified health center in Bethpage, Nassau County. The applicant currently provides mental health services through their Diagnostic and Treatment Center licensure. The proposed mental health, they're proposing a mental health clinic, which they're saying is being necessitated by the increase in the number of people that they're serving. The clinic will provide all required services and optional services of developmental testing, psychological testing, psychiatric consultation. It will operate Monday through Thursday, 8:30 to 7, and Friday from 8:30 to 5 p.m. This is the one question I didn't ask really of all majors. I imagine that the services in the licensed clinic would get the FQHC rate, a higher rate?
Yes.
Yes.
Well, okay. We recommended approval of this clinic proposal as well.
Okay, is there any discussion? Questions? Okay. You know you're making the motion.
Yes.
For approval on behalf of the committee. Is there a second?
Second.
All in favor, say aye.
Aye.
Any opposed? Any abstentions? Passes unanimously.
Okay, next is really a change of ownership or a merger. I believe that this is a two-part. This is a two-part. This Epic family of human service agencies submitted a certification proposal to become the sponsor parent entity of South Shore Child Guidance Association Incorporated. Epic Long Island is a not-for-profit that serves individuals with epilepsy, developmental disabilities, mental health challenges, and is licensed by OPWDD and the Office of Mental Health. South Shore Child Guidance Association is also a New York not-for-profit that provides comprehensive outpatient behavioral health services in Nassau County, including outpatient substance abuse treatment and an OASIS licensed Article 32 outpatient clinic. This is currently a merger. They've been in the management agreement since, I'm not sure when, but I think a couple of years. And this is really the part to approve the merger at this point. I said it's a two-part because given that they have licenses from both OMH and OASIS, we have a similar proposal also from PAR from one from OASIS and one from OMH. So we have to do one at a time.
That's a good question. So a question for the agencies: do we need to discuss and vote on these separately, or can we do it in one motion?
I think there should be separate votes.
Yeah, I think it's the same application, so the discussion can be one discussion, but I think there have to be two separate votes. Okay, all right, makes sense. Thank you.
So the committee recommended approval of the application by Epic Family Human Service agencies. So we recommend approval.
You recommended approval for both agencies,
yes.
For both parts.
Yes.
Okay. All right. Is there any discussion? Okay, then we'll proceed to a vote. So, why don't you make a motion for one or the other? We'll start with that.
We'll make a motion on behalf of the committee that we approve the Epic Family of Human Services Agency proposal to become the sponsor and to have change of ownership or merger.
And we'll start with OMH. Okay. So this first, the call will be on the OMH application.
Mm-hmm.
So there is a motion. Is there a second? Okay. All in favor, say aye.
Aye.
The opposed? The abstentions? I should have asked any exemption or any just conflicts, but there being none. Okay, it passes unanimously. And now we'll go to the OASIS application.
The committee reviewed and approved the recommendation to the full council to approve change program sponsor for South Shore Child Guidance Association to merge with Epic Long Island. I recommend on behalf of the committee approval.
Okay, so the motion is for approval. Are there any conflicts or disclosures? Okay, is there a second?
Second.
All in favor, say aye.
Aye.
Any opposed? Any abstentions? Passes unanimously.
Next is Hillside Children's Center. Hillside Children's Center proposes to reduce capacity at the Hillside Children's Center residential treatment facility from 42 beds to 34 beds. The RTF is located on 83 Monroe Avenue in Rochester. There's been a decline in utilization across the state of residential treatment facilities. Thereby, they're trying to sort of right-size their system, it seems. With this reduction, the RFT will believe that they'll be operating at capacity. Proposal addresses a national and statewide trend to decrease from the use of RTF beds, and they're like again trying to reduce capacity so they can right-size their system. The committee reviewed this and recommended that the council approve it. So make a motion that it be approved.
Okay.
Second.
Are there any second? Okay, we have a second. Are there any conflicts or disclosures? Any discussion? Okay, all in favor say aye. 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 Any opposed? Any abstentions? Passes unanimously.
Okay, now we move to Oasis. First, Exodus Transitional Community. Exodus Transitional Community submitted an application to become an Oasis provider of 822 outpatient services in location up in Harlem. Exodus has been established at this location for over 13 years. The outpatient will be in a building that they're currently inhabiting. This is a program that works, that does really prison reentry. They do in-reach within prisons, state prisons, and then transition prisoners generally on parole back into the community, and have determined that many of the prisoners that they're working with have substance use issues, and are looking to now have a licensed program so that they can help them. They have most of the prisoners that transition out of prison remain within the Harlem area. They're close by to the clinic. They also indicated that they would take people from the community that needed outpatient services. We reviewed this. The local governmental unit in New York City recommended approval. The downstate office also recommended approval. They have the support of the community board, among others. And we recommended approval on this.
So you're making a motion?
Motion.
Is there a second?
Second.
Okay, are there any conflicts or disclosures? Any discussion? All in favor say aye. Aye. Any opposed? Any abstentions? Passes unanimously.
All right, this is another change of ownership. This is South Brooklyn Medical Administrative Services. The applicant submitted a certification application requesting a change of ownership, which currently reflects the operating certificate. It's an opiate treatment service located at 685 3rd Avenue in Brooklyn. This particular program was owned by a husband and wife, Dr. Arthur Sachs and his wife, Mary Sachs. Recently, Dr. Sachs passed away, and now Mary Sachs will be the new owner should this be approved. It's been recommended for approval by the local governmental unit and the Oasis Field, New York City's field office in New York City. She has been vice president and has worked within the program for many years. I'm not seeing here how long, but she has extensive experience in working in the methadone clinic. So we recommended approval. So I make a motion that we approve it.
Okay, is there a second?
Second.
Any conflicts or disclosures? Okay, all in favor say aye. Aye. Opposed? Abstentions? Passes unanimously.
This is, again, an application for new 822-4 outpatient service. This is New Horizon Counseling Center. New Horizon Counseling Center submitted a certification application requesting to become a new OASIS provider, Part 822-4 outpatient services, located at 50 West Hawthorne Avenue, 3rd floor, Valley Stream, New York. These services were previously provided by Peninsula Counseling Center. However, Peninsula has elected to discontinue many of its services, including OASIS, OMH, and OPD, WDD services. Matter of fact, New Horizon has been taking over all of the services, including this outpatient program. They have the support of Nassau County, New York City Department of Health and Mental Hygiene, and also OASIS, and we recommended approval on this. I would make a motion to approve.
Is there a second?
Second.
Any conflicts?
Yeah, I'll just disclose I'm a former CEO of Peninsula Counseling Center.
As a former, do you have any?
Well, I was associated with the sponsor of Peninsula Counseling Center, but it's deal.
So whatever you'd like to do.
Yeah, I'll recuse.
Okay, that's fine. So John Caston recuses himself. Is there any discussion? All in favor then? All in favor say aye. Aye. Any opposed? John Caston is abstaining. Anyone else abstaining? Okay, it's approved.
Right, the last is the capital project. Bureau Certification Systems Manager in the New York State Office of Alcohol and Substance Abuse Services received the above submission on January 31, 2014 from Vocational Instruction Project Community Services, which is known as VIP. A request to relocate their Part 822-4 Chemical Dependence Outpatient Program, their opiate treatment program, and their intake and administration office for 5 OASIS certified programs from 1910 Arthur Avenue in the Bronx to a new proposed site, 770 East 176th. The certification application includes the capital project proposal for the demolition of the existing building and construction of a new facility at 770 East 176th Street. We have reviewed this. It's obviously supported by OASIS. We recommend approval. And the amount, what is the amount on this?
$22 million.
The amount is $22,511,000. So they're actually moving from one building to another building. The building's going to be renovated.
So you're making a motion for approval. Okay. Is there a second?
Second.
Any conflicts or disclosures? Discussion? Okay, all in favor say aye.
Aye.
Opposed? Any abstentions? Passes unanimously. Thanks very much to the committee. Thanks to Tino for pinch hitting as the chair. The next item on the agenda, is there anyone here for public comment?
No, there isn't. Well,
Okay, thank you. Is there any new business?
I just wanted to remind everyone that the next meeting of the council is on September 30th. And that is a full face-to-face council meeting. So everyone will be in Albany at the OASIS offices at 1450 Western Avenue. We will be in touch with each of the committees because I know that we've tried to do more substantial presentations on the issues of the agency which conflict with some of the committee meetings. So we do have funding if you need to come in the night before for those meetings and get those done early, and then we can move on to some of the substantial presentations that you've asked for. I also want to announce that Commissioner Sanchez at the ASAP conference in October gives several awards out to individuals within the field of substance use disorder, recognizing their dedication and accomplishments in the field. There's an award for prevention, treatment, recovery. There's an award for young adults 18 to 25, and there's an adolescent award, 18 years old and younger. The information regarding nominations is available on our website, but one of the things that she asked of the advisory council is she could get some volunteers to serve as an ad hoc committee to review the nominations that come in from the field and make recommendations for the awards that will be given in October. So what we'd like to do is see if there's some individuals here who might be willing to serve on that ad hoc committee. We will send you the nominations, and usually it takes one conference call and then working with the commissioner, and maybe another one working with the commissioner on the nominations that are submitted. So I have Bill Getman, Patrice Wallace-Moore. We get somebody from the Rochester group? No?
I will. John Lee.
Thank you, John. Okay, thank you very much.
They double our salary for coming to the meeting, too.
That was our secret.
Go up, we'll triple it.
Thank you.
Dr. Brown?
I'd like to, many of you know Dr. Martin and I serve on the Public Health Planning Council, and they too have committee meetings as well as full council. I was wondering if we can think about ways in which to put out the word for people to attend our committee and council meetings, because when the Public Health Planning Council meets in their committees, it is a substantially more greater number of New York State citizens who come to attend those. I really think that given how important behavioral health is to the health of New York State, that we should do something to try to inform and encourage more participation to hear about the great things that are done by this council.
Dr. Brown, this is Pat. Just to inform you, we, prior to the advisory council meeting, the advisory council is posted, the meeting is posted on our website, also on the OMH website, which has an advisory council webpage. We post the agenda, we post the date and time of the meetings, we post the full calendar of meetings on the website. So any other suggestions that you have regarding getting the word out would be greatly appreciated.
Social media, Twitter.
Well, we thank you for that information. This gives us a starting point to know where the direction we can go.
What is it like Twitter?
The meetings are in New York City. The meeting is downtown.
Twitter.
90 Church Street. And similar to this, they have meetings in Albany and they have meetings also in Rochester.
Do we know?
Any other new business or announcements?
This is Stephanie. I just had a follow-up question. Do we know how many people access the webcast? If anyone does?
We do have that information, but what we do is we also post it after the meeting. So I'm not sure if we can get the number that access the posting, but we can see.
Yeah, because I think if we're going to talk about this, we should know too. Maybe people are watching while they're, or listening while they're sitting at their desk doing other things, and so we should know more about that. But I do think somebody mentioned Twitter, and the more we can put out, like on the agency Facebooks, like that there's a public opportunity to comment. I think that's really helpful. And by the way, really, I've been loving both agencies doing a lot of great stuff on Facebook lately. Which has been really nice and easy for networks like ours that really operate a lot through Facebook to share information. So the more we can do that, the better.
Okay, any other business? Okay, what we'll do now then is in a moment I will gavel out this meeting of the Behavioral Health Services Advisory Council and turn it over to Scott Levine, who will chair the Integrated Block Grant Committee meeting. So we have a motion to adjourn the Advisory Council by everyone. Seconded by everyone. All in favor? By everyone. So thank you all very much. And Scott,
Okay.
I'll turn it over to you.
Very good.
Okay.